This is Dr. Raj Chandwaney. I'm an interventional cardiologist at the Oklahoma Heart Institute in Tulsa, Oklahoma. This is a case of a complex retrograde right coronary artery chronic total occlusion percutaneous coronary intervention. The patient is a 50-year-old gentleman who was referred for ongoing angina refractory to maximally tolerated medical therapy. The patient has a remote history of a right coronary artery stent which was placed approximately 5 years earlier. Because of his symptoms, he was referred for a myocardial perfusion study which did suggest ischemia in the territory of the right coronary artery. His ejection fraction is noted to be normal. He recently underwent a coronary angiogram at an outside facility which reveals severe single vessel coronary artery disease involving an aorto-ostial right coronary artery chronic total occlusion within a previously placed stent. His past medical history is most remarkable for his history of coronary artery disease, hypertension, and hyperlipidemia. He does continue to smoke tobacco. It should be noted that the patient does have a prior history of a sternotomy. It is not due to coronary artery bypass graft surgery. He actually underwent surgical resection of a mediastinal teratoma at age 13. It was treated with surgery and radiation. Physical examination is unremarkable. This initial angiogram reveals the right coronary artery chronic total occlusion, which is noted to be present at the very origin of the vessel. It does appear to be within a previously placed stent. Dual guide catheter angiography does reveal that the distal segments of the right coronary artery fill via an arcade of septal collaterals. The length of the chronic total occlusion appears to be less than 20 millimeters. Aorto-ostial coronary chronic total occlusions can be very challenging. The great challenge is due to the fact that the antegrade guide catheter usually has difficulty achieving stable position. Although we anticipated this, we initially attempted to approach the chronic total occlusion using a hydrophilic guide wire and an antegrade approach, just in case we might get lucky. After trying to engage the chronic total occlusion with the hydrophilic guide catheter, guide wire, our guide catheter repeatedly disengaged from the vessel. After briefly attempting an antegrade approach, we confirmed that a retrograde approach would be required. We proceeded with a left coronary angiogram to demonstrate our septal collaterals prior to attempting septal surfing. To better understand the anatomy of the first septal perforator, we performed a selective angiogram by placing the tip of a turnpike LP microcatheter in the proximal segment of that vessel. Septal surfing was then performed. In this angiogram, it is demonstrated that the tip of the wire has crossed the septal collateral and is in the distal segment of the right coronary artery. To confirm positioning in the true lumen of the vessel, we performed an oblique angiogram in an LAO projection. This again confirms placement of the wire tip in the true lumen of the vessel, and then it's advanced more proximally in the right coronary artery. The next step to perform our retrograde procedure would require us to advance a microcatheter across the septal collaterals. When attempting to do so, the microcatheter tip was stuck at this location. It could not be advanced further. To try and overcome this obstacle, we performed angioplasty of the septal collateral using a 1.2 millimeter Trek angioplasty balloon. The balloon could not be advanced beyond this current location. Several inflations were performed with the 1.2 millimeter Trek angioplasty balloon. Another inflation more proximally in the septal perforator. We were able to advance our Turnpike LP microcatheter further than it originally traveled, but it did become stuck at this location. We then utilized an ultra-low profile 1 millimeter sapphire balloon. We were able to advance this balloon all the way through the septal collateral, and we performed angioplasties again in the septal collateral. Additional angioplasty being performed slightly more proximally with our sapphire 1 millimeter balloon. Another angioplasty more proximally with the sapphire 1 millimeter balloon. This angiogram is meant to demonstrate advancement of a of a fine cross microcatheter. We switched to the fine cross microcatheter because of its lower profile. Also, to achieve this step, we optimized our support in the retrograde system using a guide liner. By combining all of these techniques, we were finally able to advance the fine cross microcatheter tip across the septal collateral into the distal segment of the right coronary artery. Then we exchanged out our Fielder FC intracoronary guide wire for a Pilot 200 intracoronary guide wire. This wire was used to cross the chronic total occlusion. Here you can actually see the wire cross the occlusion and enter the aorta, and then the wire becomes to change its directionality because of flow through the aortic valve. Because we were unable to maintain stable antegrade guide catheter positioning at the ostium of the right coronary artery chronic total occlusion, we decided that we would attempt snaring of the retrograde wire into the antegrade guide catheter. Rather than attempting snaring in the ascending aorta, which is usually much more difficult and time-consuming because of the large size of the ascending aorta relative to the size of available snares. Instead, we directed the tip of our guide wire up towards the brachiocephalic artery. We then deployed a 25 millimeter snare in the brachiocephalic artery before we advanced our Pilot 200 intracoronary guide wire into the brachiocephalic artery. It should be noted that when a wire is advanced up the aorta, it tends to travel into the brachiocephalic artery because of preferential flow towards the brain. It allows much easier snaring at that location than is usually achieved in the ascending aorta. We then carefully seated the guide catheter into the origin of the right coronary artery. We advanced our fine cross catheter tip into the antegrade guide catheter. We then removed the Pilot 200 intracoronary guide wire and exchanged it for a R350 intracoronary guide wire, which was long enough to be externalized. We then performed angioplasty using an antegrade approach over the externalized R350 guide wire. Here we are performing angioplasty at the mid-segment of the vessel, more proximally in the proximal to mid-segment of the vessel, and here in the very proximal segment of the vessel. Repeat angiogram was performed before stenting. We then deployed a 3.5 millimeter by 38 millimeter Zions Sierra drug-eluting stent in the mid-segment of the vessel, a second 3.5 by 38 millimeter Zions Sierra drug-eluting stent in the proximal segment of the vessel. The very proximal area was post-dilated using a 4.0 by 20 millimeter NC Trek angioplasty balloon. An excellent result was achieved after stent deployments. Before removing our retrograde equipment, we did check our septal collaterals to make sure there was no obvious perforation present. then we could safely remove our retrograde gear. This was a complex case which required a retrograde approach due to the aorto-ostial location of the chronic total occlusion. During the retrograde approach, there were several obstacles that needed to be overcome to complete the procedure successfully. Specifically, we had difficulty advancing a microcatheter across the septal collaterals. This obstacle was overcome by increasing our guide support with a guide liner, performing septal angioplasty, and switching to a smaller fine cross microcatheter. Additionally, we had difficulty advancing a wire into the antegrade guide catheter because of the challenges we observed maintaining guide catheter stability at the ostium of the vessel. Therefore, the retrograde guide wire had to be snared into the antegrade guide catheter. Rather than attempting this step in the ascending aorta, we more efficiently performed this step by advancing the wire into the brachiocephalic artery, where snaring can be achieved much more easily. Thank you very much for your interest in this case.